Hello, this is Justin Ansela, and this is my Unit 2 Case Connections video. I've chosen Case 2 and Case 4, and we'll start with Case 2. And we'll start with the question. Use the following series of questions to determine how, if glucose uptake differs in the tumor when compared to surrounding tissues. In normal tissue, how is glucose uptake regulated in the following tissues? Glucose uptake during physiologic homeostasis will be prioritized to organs that have higher metabolic activity. A perfect example would be the uptake by the brain of fluorescently labeled D-glucose on a normal PET scan, whereas tissue with lower metabolic activity during physiologic homeostasis have significantly less fluorescently labeled D-glucose uptake. Specifically regarding the certain tissues, we'll start with the liver. Liver glucose uptake is regulated by whether or not we are in the fed versus fasted state and mediated by the insulin-independent glucose transporter GLUT2. In the fed state, where carbohydrates are readily available, glucose is converted into glycogen via glycogenesis to be stored. Again, when carbohydrates are plentiful, they can also be converted into fatty acids via lipogenesis using acetyl-CoA, where the fatty acids are incorporated into the very low-density lipoproteins for transport to adipose tissue. Moving on to skeletal muscle. Skeletal muscle glucose uptake is dependent on metabolic activity and mediated by the insulin-dependent glucose transporter GLUT4, as well as current stores of glycogen. At physiologic homeostasis, skeletal muscles will contain about 500 grams of glycogen. Skeletal muscle inhibits excessive stores of glycogen via the feedback inhibition of glycogen synthase. Glucose uptake in skeletal muscles can be diminished by insulin resistance, seen in type 2 diabetes mellitus. This resistance can be circumvented utilizing the muscle contraction-induced glucose uptake, which is insulin independent. Moving on to the brain, glucose uptake in the brain is mediated by insulin-independent glucose transporter GLUT3. The brain utilizes glucose as its primary fuel for the creation of ATP. In addition, neurons have the highest energy demand, which requires a continuous delivery of glucose. In humans, the brain consumes upwards of 20% of the glucose-derived energy of the body, albeit the fact that it only constitutes about 2% of our body weight. In the brain, glucose can either be oxidized to produce ATP or used to synthesize glycogen. The brain has a complex regulatory system to preserve its glucose supply at all times. Adipose tissue. Adipose tissue glucose uptake is mediated by the insulin-dependent glucose transporter GLUT4. In the fed state, where carbohydrates are in excess, hence glucose will be in excess, the glucose will be transported and taken up by more preferential tissue such as brain, liver, skeletal muscle, and the excessive glucose will be taken up by the adipose cells and converted to fatty acids, which will undergo esterification to triacylglycerol. Moving on, how does glucose uptake in the normal tissue compare to glucose uptake by tumor cells in the above image, and why would this be advantageous to the invasive tumor? Glucose uptake by our normal cells is regulated by the organ-specific metabolic activity, whether there is insulin resistance, and on the availability of tissue-specific glucose transporters. To the contrary, tumor cells have to adapt their metabolism to survive and replicate under a metabolically unfavorable environment, namely aerobic glycolysis. Tumor cells rely on a constant supply of energy through a series of alterations in their metabolism where they can maintain upregulated and unregulated cellular proliferation and survival. This increase in metabolism is needed to sustain the tumor cell's continued proliferation. This results in an increased unregulated uptake of energy and preferentially glucose. Therefore, a PET scan measures glucose uptake where tumor cells have high and unregulated levels of glucose uptake compared to normal cells. The next question is, what modifications may have occurred in cancer cells to alter glucose uptake as predicted above? As stated in the answer above, tumor cells have adapted their metabolism to survive and replicate under metabolically unfavorable environments. Notably, a majority of the tumor cells carry genetic alterations that lead to inactivation of tumor suppressor proteins. Tumor cells have undergone metabolic shifts that support tumor cell growth and survival, where this requires increased energy in the form of glucose. Moving on to case 4. So based on case 4, based on the information above, which of the following is the most likely diagnosis of the patient? I'll discuss the correct answer first. So the correct answer is C, glycogen storage disease, which is the inability to use glycogen. A deficiency whereby you lack the enzyme glucose-6-phosphatase, which is required for glycogenolysis and gluconeogenesis. Glucose-6-phosphatase is required to dephosphorylate glucose-6-phosphate to generate free glucose, thereby impacting gluconeogenesis and glycogenolysis, can lead to hypoglycemia. This condition results in the accumulation of glycogen and fat in the liver and kidneys and is associated with hepatomegaly and renomegaly. A well-described glycogen storage disease is von Gurk disease. Epinephrine has a minimal effect on the blood sugar and increases serum lactate levels significantly. Growth retardation is associated with this disease as well. Moving on to the incorrect answers, we'll start with A, hereditary fructose intolerance. Hereditary fructose intolerance is caused by a deficiency in aldolase B, which results in accumulation of fructose-1-phosphate. This condition can cause clinically significant symptoms such as hepatomegaly and fasting hypoglycemia. The accumulation of fructose-1-phosphate will ultimately inhibit both the processes of glycogenolysis and gluconeogenesis due to the lack of free phosphate. In the scenario above, the patient presents with jittery spells and sharp bouts of sleep, which are classic for hypoglycemic events. Epinephrine would cause an increase in liver and muscle glycogenolysis, which is being inhibited in the 2-month-old female infant in the scenario due to the lack of free phosphate. But epinephrine would not affect the lactate levels in this condition. The next incorrect answer is galactosemia. Galactosemia is when an enzyme known as galactose-1-phosphate uridyl transferase, otherwise known as GALT, is deficient, which results in an elevated level of galactose-1-phosphate in the liver. This is significant because increased levels of galactose-1-phosphate in the liver can inhibit hepatic glycogen metabolism as well as become toxic to the liver itself. Elevated levels of galactose-1-phosphate can be toxic to the kidneys and CNS as well. Patients with classic galactosemia will present with feeding difficulties, lethargy, jaundice of the skin and eyes, possibly abnormal bleeding, and growth deficiencies in height and weight. Epinephrine would not have an impact on this condition either. A key difference in this condition as compared to the hereditary fructose intolerance is this condition is associated with poor feeding. The next incorrect answer is glucose-6-phosphate dehydrogenase deficiency. Glucose-6-phosphate dehydrogenase is an important enzyme in red blood cell metabolism, specifically for reducing NADP plus to NADPH. This key role in red blood cell metabolism allows sufficient NADPH levels to maintain glutathione peroxidase. Glucose-6-phosphate dehydrogenase deficiency is the most common of all enzymopathies. Glutathione reduces organic peroxide and hydrogen peroxide as a defense against lipid peroxidation. In effect, this deficiency causes hemolytic anemia. Patients with this deficiency will present with painless jaundice, dark urine, elevated heart rate, and trouble breathing. That concludes my Unit 2 Case Connections video. Thank you for your time.